Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. And you must be aware that all our lectures are available on YouTube. You can access all the lectures in the YouTube and the playlist. We also have a Telegram group where you can get all the information regarding the upcoming lectures and how to access them. We have a Google Drive where all the PDF is available with the master integration key to navigate through them. These are the disclaimers. And we are in phase 3 and we are in dermatopathology, which is Pursue 26. And continuing with dermatopathology today, we have a lecture on skin adnexal tumors, which is sebaceous tumors, and we are streaming live from Chidambaram. To talk on this, we have Dr. Sandyya Umamahesweran. She's an MD from JIPMER, and she's also done her DNB. Presently, she's a consultant pathologist and lab in charge of Chidambaram Diagnostics and Scan Center, Chidambaram, with her areas of interest in dermatopathology, cytopathology, surgical pathology. She's got multiple publications in international and national journals, was awarded the DJ Reddy Memorial Prize for the best postgraduate in pathology from JIPMER, Puducherry. She's also worked there as a senior resident. And today, Dr. Sandyya will be talking about skin adnexal tumor. This is the first lecture on the skin adnexal series of tumors, and this will be on sebaceous tumors. Over to you, madam. Thank you so much.
A very good evening to all. Today I'll be talking about skin adnexal tumors, focusing particularly on sebaceous tumors. Cutaneous adnexal tumors are a heterogeneous group of neoplasm which differentiate towards a particular appendageal structure, such as sebaceous glands, acrine and apocrine glands, or hair follicle. So we'll start with the histology and embryology of the appendageal structures, which is important to understand the histogenesis of these tumors and what are the 5 S to consider before labeling a particular cutaneous adnexal neoplasm, and the classification of cutaneous adnexal tumors, detailed analysis of sebaceous tumors, syndromic association, role of immunohistochemistry and other ancillary techniques. Cutaneous appendageal structures are sebaceous glands, acrine and apocrine glands, and hair follicle. The key functions of these appendageal elements are protection, lubrication through secretion of sebum, thermoregulation and electrolyte balance, and secretion of drugs and other things through sweat. We'll start with the histology of sebaceous glands. So, sebaceous glands. Sebaceous glands are a group of holocrine glands. Holocrine means the entire cell is destroyed in the process of secretion of sebum, and the entire cell is secreted into the glandular lumen. Sebaceous glands are always associated with hair follicles. A pilar unit comprises of a hair follicle, sebaceous glands, and erector pili muscle, and acrine and apocrine glands when present. Sebaceous glands are commonly seen on the face, buccal mucosa, vermilion of the lip, and prepuce, and labia minora, and rarely in parotid gland. If you look at the basic histology of sebaceous glands, they are nicely lobulated, and the lobules comprise of numerous acini. And the basic cell is a sebocyte, which is a multivacuolated cell with a scalloped centrally placed nucleus. Due to the nucleus is scalloped due to lipid imprints. The main function of sebaceous glands is secretion of sebum and lubrication. And the basic immunostains that are positive in sebaceous glands are CK15, which is a follicular stem cell marker, and EMA. Hair follicle. So the structure of hair follicle is a little bit complex, but we will go in depth about hair follicle while discussing the tumors of follicular differentiation. For now, let us understand that hair follicle has 3 segments from top to bottom: infundibulum, isthmus, and inferior segment. At isthmus, what happens is there is an outer root sheath and an inner root sheath. At the isthmus, that inner root sheath disintegrates into the outer root sheath with an abrupt keratinization, with without the presence of granular layer. So that type of abrupt keratinization where the granular layer is absent is called as tricholemmal keratinization. This is very essential to differentiate epidermal tumors from tumors of tricholemmal origin. And here I want you to take a look at two things. One is the clear cells that are present in the outer sheath, and the reddish granules, that is the trichohyalin granules that are present in the inner root sheath. So these trichohyalin granules are distinct, different from the keratohyalin granules, which we see in squamous cells, which are basophilic. Here, these granules are red in color. And these clear cells are morphologically seen in certain tumors of hair follicle. We will see that in detail when we discuss tumors of follicular differentiation. Eccrine glands. Most important function of eccrine gland is thermoregulation. These are more concentrated on palm, soles, forehead and axillae. They have a dual function, secretory and excretory function. This here represents the excretory portion of eccrine glands, and these convoluted ducts represent the secretory portion. The cross section of these look like this with a lumen. So there are three types of cells: clear cells, dark cells and myoepithelial cells. Clear cells are pale or finely granular cytoplasm with round nucleus, and they show abundant mitochondria and glycogen. Dark cells show mucopolysaccharide and proteins, and myoepithelial cells are contractile spindle cell, contraction of which expels the secretion. These are the clear cells of eccrine glands, and there are these dark cells. These clear cells are very important to note because these are seen in certain tumors of eccrine differentiation. Apocrine glands. Apocrine glands are secretory glands located in the deep dermis and subcutis. Apocrine means there are detached fragments of apical cytoplasm that are found in the lumen. Like just as we saw in holocrine, where the entire cell gets lost along with the secretion, for apocrine glands, the tip of the cell gets detached and is discharged into the lumen along with the secretion. If you notice here, there is this protrusion kind of thing in the apical region of the cell. So that is the apical part of cytoplasm containing the secretion which gets detached and gets discharged into the lumen. So for apocrine glands, remember these two A's, axilla and anogenital areas, because apocrine glands are concentrated more in the axilla and the anogenital areas. AAA, it is easier to remember: apocrine, axilla and anogenital areas. Histology wise, there is one layer of cuboidal or columnar or flat cell depending on the secretory activity, and an outer layer of myoepithelial cells. The luminal cells contain eosinophilic cytoplasm, which is rich in lipid, lipofuscin, and nucleus is present in the base of the cell. IHC wise, apocrine glands are positive for gross cystic disease fluid protein 15 and EMA. Myoepithelial cells lining the secretory sweat glands are positive for SMA and CK17. Let us look at the basic embryology of the epidermal appendages. Epidermis and the appendages arise from ectoderm, which is the primary epithelial germ. The epithelial cells of the skin appendages such as sebaceous, apocrine and eccrine, they develop from follicular epithelial stem cells from the bulge region of the developing hair follicle, which houses multipotent stem cells. This word here is vital because it is these multipotent stem cells that have marked plasticity that differentiate into various tumors along the lines of sebaceous, follicular, eccrine and apocrine tumors and so on. So these multipotent stem cells are housed in this bulge region that has a dermal papillary mesenchyme, and the ectoderm, the germ cells from the basal layer, they invaginate and enclose the dermal papillae. So these follicular epithelial stem cells, they form the outer root sheath of the hair follicle, and epithelial buds that invaginate from the outer root sheath of the hair follicle gives rise to sebaceous lobules and apocrine glands. Acrine glands, they arise from the fetal epidermis. They bud from the fetal epidermis independent of the hair follicle. And that is why most of the time sebaceous glands are almost always seen in association with hair follicle, and so are apocrine glands. Pilosebaceous unit comprises of hair follicle, sebaceous glands, and apocrine glands when present and surrounded by erector pilemus. Let us look at the histogenesis of adnexal tumors. So it was hypothesized that adnexal tumors may arise from primary epithelial germs, multipotent stem cells, and cells from pre-existing structures. The possibility that tumors arise from cells from pre-existing structures are less likely. Probably the hyperplasias and hematomas, they arise from a fully differentiated and a mature cell, whereas the various other benign and malignant adnexal tumors are likely to be originating from multipotent stem cells, because these multipotent stem cells, which we saw previously, have marked plasticity. They have the ability to differentiate into any type of cell. So that is why these stem cells can differentiate along the lines of sebaceous or acrine or apocrine glands or hair follicle. So these multipotent stem cells manifest more than one differentiation pattern. Even in certain tumors, we see all three types of differentiation in the same tumor itself. That is because of the plasticity of these multipotent stem cells. And these multipotent stem cells have the ability to differentiate along any cell type. So sporadic as well as in syndromes, these are genetically predisposed to proliferate and form tumors with altered appendageal structure. Before we delve into the topic proper, let us wait for a second, stop, consider, and remember the following things. When we look directly at the histomorphology of cutaneous adnexal tumors, we get lost sometimes by the similarity, by the overlap. Like I said previously, many type of differentiation may be present in a single tumor, and a lot of confusing entities will come under differential diagnosis. So let us remember and approach it in a methodical way. Let us first approach a cutaneous adnexal tumor and consider, can it be a benign tumor or a malignant tumor? Can it be a primary cutaneous tumor or a metastatic tumor? Certain tumors like microcystic adnexal carcinoma, their histology mimics metastatic tumors. Is it syndromic? A lot of cutaneous adnexal tumors are seen in association with syndrome. It is important to pick up these syndrome from a cutaneous manifestation because they may harbor an internal visceral malignancy that could be dangerous. So when we pick it up from a cutaneous manifestation of the syndrome, it becomes easier to diagnose and treat the patient. So to approach whether it could be syndromic, let us remember that sporadic tumors are single, whereas multiple tumors are seen in syndromes. Multiple cutaneous manifestations are seen in syndromes. And the line of differentiation. There are pointers towards particular type of differentiation. Sebocytes are present in sebaceous tumors, and a lot of pointers like palisading and a particular type of stroma, they are seen in follicular tumors, and various other differences are seen in acrine and apocrine tumors, which we will see in detail when we consider all those tumors separately in detail. In adnexal tumors and the 5S, let us remember these 5S before arriving at a particular diagnosis of a cutaneous adnexal tumor. So what are these 5S? Similarity. Similarity of one adnexal tumor with other adnexal tumor, as well as with epidermal tumors. For example, a sebaceous carcinoma may mimic a basal cell carcinoma with sebaceous differentiation or a clear cell squamous cell carcinoma. Presence of basaloid cells. Basaloid cells are invariably seen in a lot of tumors and they could be confusing. And syndromic association. For example, Myotvar syndrome, which we'll be seeing in detail later, and Brooks-Pigler and other related syndromes are seen in association with cutaneous adnexal tumors. Cutaneous adnexal tumors have specific sites. Sebaceous tumors invariably arise from face and scalp. And likewise, a lot of cutaneous adnexal apocrine tumors are seen in the axillary and anogenital region. So let us remember the clinical presentation, whether they are single or multiple, and then look at histology and other features to arrive at a particular diagnosis. Cutaneous adnexal tumors are synonymous. We should not get trapped in the nomenclature because they are very confusing at times. Sebaceoma, sebaceous adenoma, these similar sounding names should not trap us. Syringoma, cylindroma, chondroid syringoma, likewise. And stroma, many a times, along with the particular cells, the stroma will also, the adjacent stroma will also help in arriving at a particular diagnosis. Mucinous stroma, the collagenous stroma, sclerotic stroma, likewise. So let us learn how to differentiate a benign adnexal neoplasm from malignant adnexal carcinomas. Benign adnexal neoplasm are symmetrical and they have a rounded border circumscribed when you look at scanning magnification, whereas malignant adnexal carcinomas are asymmetrical and they have irregular borders and they are infiltrative. They are vertically oriented with respect to the surface of the skin, whereas malignant adnexal carcinomas are horizontally oriented. Like the benign adnexal neoplasms, they are so circumscribed that they may resemble somewhat this, whereas malignant adnexal carcinomas, they will manifest like this, horizontally oriented with respect to skin, and they are irregular and they are infiltrating and so on. And whereas these are very circumscribed. So densely fibrotic stroma are usually present in benign adnexal neoplasm. There are always exceptions, and malignant adnexal carcinoma, they show infiltration of dermis and subcutis without interposition of the densely fibrotic stroma. In benign adnexal neoplasm, there is usually no necrosis in mass, whereas in malignant adnexal carcinoma, there is areas of necrosis. Mitosis are frequent in benign, but they are typical, whereas atypical mitotic figures are seen in malignant adnexal carcinomas. And in benign adnexal neoplasm, we usually have aggregates of uniform epithelial cells, whereas malignant adnexal carcinoma, there is loss of polarity and there are irregular epithelial aggregates. And there is the nuclei is monomorphic in a benign adnexal neoplasm, whereas in malignant adnexal carcinoma, we see pleomorphic nuclei. Let us move on to the WHO classification of cutaneous adnexal tumors. As you all know, WHO classification goes like this, and this is the most recent classification which is published online. A book will be published later this year. So tumors of apocrine and ecrine differentiation, not much of a change from the previous edition except for this new entity which is added, NUT carcinoma of malignant ecrine tumors. NUT, as you all know, is nuclear protein of testis. We will see in detail when we deal with apocrine and ecrine tumors. These are tumors of follicular differentiation. Today we'll see in depth about tumors with sebaceous differentiation, which are sebaceoma, sebaceous adenoma, and sebaceous carcinoma. And just take a look at these site-specific appendageal tumors. You will all be familiar with hidradenoma papilliferum, fibroadenoma, and phyllodes tumor of anogenital mammary-like glands. And malignant site-specific appendageal tumors are mammary Paget disease, extramammary Paget disease, and adenocarcinoma of mammary gland type. So let us move on to tumors of sebaceous differentiation. Before approaching the tumors of sebaceous differentiation, please remember this illustration. This is the illustration of a multivacuolated sebocyte. There are sebocytes in each of the sebaceous tumors, which are pointers for sebaceous differentiation. The sebocyte is rich in lipid vacuoles, so the lipid vacuoles will indent the nuclei, causing scalloping of the nuclei. So when you approach a basaloid tumor, if you suspect it to be of sebaceous differentiation, look for these sebocytes. These sebocytes are present in varying numbers in sebaceous tumors. So the presence is a pointer towards sebaceous differentiation. The risk factor for sebaceous tumors are ultraviolet radiation, radiotherapy, immunosuppression, HIV, and human papilloma virus. Tumors of sebaceous differentiation are derived from sebaceous glands of skin or eyelid, and the common sites are face and scalp. This is the WHO classification of tumors of sebaceous differentiation, and trust me, sebaceous tumors are the simplest group of tumors among all the adnexal tumors, with lesser number of entities and less complicated classification. So for our ease, we have this classification here where there is hyperplasia, hamartoma, benign and malignant tumors. Under hyperplasia or hamartoma, we have this unique entity, nevus sebaceous of JADASSOHN and sebaceous hyperplasia. Fordyce, pot or Montgomery tumor, these are just ectopic sebaceous glands, and these are self-limiting, and they do not require much of treatment, or they just need reassurance. And among the benign tumors, we have sebaceoma, sebaceous adenoma, and among the malignant tumors, there is just one entity, sebaceous carcinoma. So this is a unique type of entity, nevus sebaceous of JADASSOHN. JADASSOHN, it is named after a German dermatologist who has contributed a lot for the field of allergy, immunology, and all. So nevus. So the term nevus might be confusing because we have always seen that in association with melanocytes and melanocytic lesions and all. But nevus in this scenario means a lesion that is usually present at birth and is composed of mature or nearly mature structures. That is why we always add the suffix nevus sebaceous. Acrine nevus, nevus flemmus, like that. And we just do not stop at the word nevus. That is why the suffix is invariably added to depict these particular type of tumors that are composed of mature or nearly mature structure. So nevus sebaceous must imply that this tumor is composed of mature or nearly mature sebaceous lobules. That's all. So these are usually seen as single lesion, commonly seen on scalp or face, and these are present at birth. They are usually seen in 3 stages: infant stage, childhood stage, and puberty stage. And when these are present at birth or the infant stage, they are usually present as a hairless patch. And as they go on, the stages go on increasing, they become raised and become like a patch, and they become nodular eventually. This particular entity is important for the association with developmental syndromes, or like Schimmel-Penning or nevus sebaceous syndrome. And a lot of bony abnormalities, mental retardation, and neuroectodermal syndromes are associated with this. And scalp syndrome, which is nothing but nevus sebaceous, CNS malformation, aplasia cutis congenita, limbal dermoid, and pigmented nevus. Nevus sebaceous are also seen in association with hypophosphatemic rickets, where there is an upregulation of fibroblast growth factor 23. Sebaceous. It is important to see the clinical picture also in association with histology when it comes to cutaneous adnexal tumors. So this is the infant stage, which depicts the hairless patch. Next stage is the adolescent or puberty stage, where you have little bit of raised lesions, and in adult stage the lesion will be verrucous or nodular. Let us look at the histology of nevus sebaceous, where in infant stage you have sebaceous glands that appear underdeveloped and cords of undifferentiated basaloid cells which are reminiscent of embryonic stage of hair follicles. In the puberty or adolescent stage, you have the characteristic diagnostic histologic appearance, wherein you have mature or nearly mature sebaceous glands overlying hair follicle, epithelial papillary hyperplasia, and association with dilated apocrine glands. If you recall from the development part, these apocrine glands, sebaceous glands, and hair follicle, they're almost always in association with one another. So this stage, puberty or adolescent stage with a characteristic histologic appearance also shows similar thing, mature sebaceous lobules overlaying papillary epithelial hyperplasia, papillomatous epithelial hyperplasia and hair follicle, and association of dilated apocrine glands. And in adult stage, there is a stage from which various other appendageal tumors develop, such as trichoblastoma, nodular hydradenoma, syringoma, and sebaceoma. So you have to be careful when you look at the histology of an adult stage tumor for the association of other appendageal tumors. So this here you see some abortive sebaceous lobules, and if you see here there is a presence of hair follicle on top, and this here represents the cord of basaloid cell. If you look at this is a case of nevus sebaceous, but the presence of this will make you think along the lines of trichoblastoma or some tumors of hair follicular differentiation. If you recall the embryology which we discussed, wherein the hair follicle unit is seen in association with sebaceous glands and apocrine glands, and these are all derived from follicular epithelial stem cell, it will make sense that one tumor can have all these varying different adnexal structures in association with one another. So nevus sebaceous, like I said, in the third stage, lot of basaloid neoplasm are arising from the third stage of nevus sebaceous. So there is a debate as to they'll differentiate towards trichoblastoma or basal cell carcinoma. It is always important to differentiate these two because of the vast treatment difference they have. So the markers that are positive in this basaloid neoplasm indicates that the origin could be from follicular or trichoblastoma. However, these tumors are negative for PHLDA1, a follicular stem cell marker. And some of the nevus sebaceous, not all, some of them show loss of heterozygosity of the Drosophila PTCH gene, which is seen in basal cell carcinoma. So that prompt towards the possibility of whether these basaloid neoplasm could be basal cell carcinoma. So if you look at the molecular pathways that are involved in nevus sebaceous, there is an increase in the RAS pathway, mainly HRAS and KRAS. And why there is alopecia in nevus sebaceous, it is interesting to see that there is increase in hair growth suppressing factor, fibroblast growth factor 5. That could be the reason for the patchy hair loss in nevus sebaceous. Also, along with it, there is decrease in hair growth stimulating factors. Treatment for nevus sebaceous is photodynamic therapy or topical application of aminolevulinic acid. What are FORDYCE'S spots and Montgomery's tubercles? These are nothing but ectopic sebaceous glands that are seen on the tip of vermilion and ectopic mature sebaceous glands on the areola, respectively. So these Montgomery's tubercles become more prominent during pregnancy and they secrete a non-milky fluid. So if you notice, the FORDYCE'S spots are minute globoid lesions on tip of the lips, the vermilion border they call it, the vermilion border of the lips. So if you look at the histopathology, you will see a group of small mature sebaceous lobules situated around a small sebaceous duct leading to the surface epithelium. These lesions usually resolve without any intervention and you have to give reassurance. Pitfall alert is that the name wise, nomenclature wise, these are confusing. FORDYCE'S spot and Fox-Fordyce disease. Fox-Fordyce disease is a disease in which there is apocrine miliaria, which is commonly seen in the axilla. So don't confuse these two names. These are normal ectopic sebaceous glands situated on the vermilion border of the lip. Sebaceous hyperplasia. Sebaceous hyperplasia is usually seen on face, forehead, and cheeks, and they are usually multiple, and these are seen in elderly. This is very important because if you notice these in a young patient, you should always think of a syndromic association. However, the syndromic association is less common with sebaceous hyperplasia. So gross, there will be one or more elevated, soft, yellowish, slightly umbilicated papules. And these are 2 to 3 millimeter in diameter. The pathogenesis of sebaceous hyperplasia is that the migration of sebaceous cells from basal area into the center of lobules and towards the duct is slower. And that is because of increased epidermal growth factor and epidermal growth factor receptor upregulation. Some of the sebaceous hyperplasia could be cyclosporin induced, and some of them could be with background immunosuppression. In immunohistochemistry, there is androgen receptor positivity. This androgen receptor positivity is seen in all sebaceous tumors because androgens affect sebaceous gland growth and differentiation. So if you notice that predominant cells are the sebocytes and the sebaceous hyperplasia. If you see undifferentiated germ cells, they'll be only in the periphery and not anywhere in the center. They'll be only as a single layer in the periphery. And they're almost always open into a common duct. So if you see, there is single enlarged sebaceous gland comprising multiple lobules of sebaceous sebaceous cells that open into a common duct. Treatment of this is electrocautery or laser ablation with photodynamic therapy. When you look at sebaceous hyperplasia, you should always think about any immunosuppression or any treatment induced like cyclosporin induced, or is there any syndromic association. Sebaceous adenoma. In contrast to sebaceous hyperplasia, which is usually multiple, sebaceous adenoma presents as a solitary lesion. It is a yellowish circumscribed nodule on face or scalp, which is sharply demarcated from the surrounding tissue. It comprises of incompletely differentiated sebaceous lobules. There are two types of cells in sebaceous adenoma: undifferentiated basaloid cells and mature sebaceous cells. Mature sebaceous cells constitute usually more than 50% of cells, and the polarity is maintained. That is, sebaceous cells are present in the center, whereas the basaloid cells are seen only in the periphery. Sporadic lesions are usually solitary, and multiple lesions are associated with Nevois syndrome. Histologic variants of sebaceous adenoma are solid, cystic, and keratoacanthomatous. The cystic and keratoacanthomatous types are usually seen in association with Nevois syndrome. So when you look at a cystic pattern of sebaceous adenoma, you have to be careful. And the treatment is excision. So this is the histology of sebaceous adenoma, where you have predominantly mature sebocytes and also the undifferentiated basaloid cells that are present surrounding the sebocytes, but the sebocytes are they constitute more than 50% of the tumor cell. Always, while considering the differential diagnosis as sebaceous hyperplasia or sebaceoma, remember the gradient of differentiation: hyperplasia, adenoma, and sebaceoma. Hyperplasia has predominantly mature type of cells, and basaloid cells are like very minimal, negligible. Whereas in adenoma, you have two types of cells, but the sebocytes will predominate. And in sebaceoma, you have two types of cells, but the basaloid cells will predominate. When you have invasiveness, asymmetry, and atypia, it helps to differentiate adenoma from sebaceous carcinoma. If you notice, this is a well circumscribed tumor, rounded tumor, and it comprises of mature sebocytes, and the undifferentiated basaloid cell constitute less than 50% of the tumor cell. So there is no problem in diagnosing this as sebaceous adenoma. Sebaceoma. Sebaceoma usually presents as a solitary circumscribed nodule or ill-defined plaque, yellow in color, and it is usually seen on face or scalp. If it is present in ear or eyelid, it usually causes confusion with sebaceous carcinoma, because in this type the presence of basaloid cells are more in number. The gradient of differentiation proceeds towards slightly immature cells. And sebaceoma, if you recall from nevus sebaceous, these can arise in the third stage of nevus sebaceous. And sebaceoma are also could arise as a part of Myortois syndrome. So when you notice sebaceous adenoma or sebaceoma, which could be the single most cutaneous manifestation, you have to screen the patient for any visceral malignancy. Histopathology of sebaceoma. It is a rounded tumor with circumscribed borders, and they have rounded cellular lobules and microcystic spaces. Basaloid cell comprise more than 50%. If you see, it appears blue in contrast to sebaceous adenoma, which appeared pink. There is a unique histologic variant of sebaceoma, that is the rippled pattern sebaceoma, where you have unique arrangement of small monomorphous cigar-shaped basaloid cell in linear rows parallel to one another, resembling Verroque bodies. This type is a pitfall. It will confuse us and make us think of any other tumor of follicular differentiation. But the scattered sebaceous cell seen in between is a pointer towards sebaceous differentiation. So if you notice, there is some intermingling of sebaceous and basaloid cells, and the basaloid cells are clearly more in number than the sebaceous cell. So when you see a tumor with basaloid cell, always look for a pointer that will help you to confirm the differentiation towards sebaceous cells. So once again, before going into sebaceous carcinoma, let us recollect these differences between sebaceous hyperplasia, sebaceous adenoma, and sebaceoma. Grossly, sebaceous hyperplasia may be multiple, whereas the other two are single. Association with Myortois syndrome, sebaceous hyperplasia is less commonly associated, whereas these two are more commonly associated. And histopathology-wise, there is single sebaceous gland with multiple lobules opening into one duct, whereas in sebaceous adenoma and sebaceoma, there is a circumscribed nodule comprising of sebaceous cells more than 50% and basaloid cell less than 50%. And in sebaceoma, it is the opposite, where you have more number of basaloid cell and less number of sebaceous. Carcinoma is the only malignant entity under sebaceous tumors. That's a relief. And there are two variants of sebaceous carcinoma, mainly periocular variant and extraocular variant. Periocular variant is the most common variant, which is usually seen in eyelids, meibomian glands, and less commonly Zeiss glands. Equal incidence in male and females, and it is usually commonly metastasizing to local lymph nodes, periauricular and cervical chain of lymph nodes. Whereas the extraocular tumors are seen in head and neck, and they are usually associated with another visceral cancer, that is Myortois syndrome, and they are more seen in men. And when extraocular tumors are seen in association with Myortois syndrome, they usually will not metastasize. Whereas if they are not associated with syndrome, they are highly metastasizing. Going into the histology of sebaceous carcinoma, always remember that pagetoid tumor cell spread is common in sebaceous carcinoma. And a lot of times clinically, these pagetoid tumor spread of sebaceous carcinomas, they are usually misdiagnosed as chronic blepharitis or chronic chalazion and chronic blepharoconjunctivitis and all, and treated for so many years like that without proper diagnosis. So this clinical image is taken from this paper just to reiterate the importance of looking for pagetoid spread in sebaceous carcinoma. Pagetoid implies poor prognosis. So sebaceous carcinoma histopathology, there will be irregular lobule formation with variation in sizes of lobules. Like you have varying size lobules, and they are asymmetrical and irregular and infiltrating. There is marked cytologic atypia and increased mitotic activity. You will have frequent atypical mitosis. There are zones of necrosis, and even amidst all those things, you have these foamy cells which point towards sebaceous differentiation. There may be atypical keratinizing cells like squamous cell carcinoma, which might confuse you, but the holes that whorl formation is not seen. And in squamous cell carcinoma, you will have dyskeratotic cells, which are not seen in sebaceous carcinoma. So this is the frequent mitotic figures that I was talking about, and these are the focal sebaceous differentiation. Always look for these things in a blue tumor that will help you to make a diagnosis of sebaceous tumor. Always remember this. So this particular picture here also shows irregular infiltrating tumor comprised of basaloid cells, and intervening tumor shows these vacuolated cells that will help, vacuolated cells with marked cytologic atypia and frequent mitosis that will help you to arrive at a diagnosis of sebaceous carcinoma. So special stains, if you have a frozen section for sebaceous carcinoma and you're suspecting it to be sebaceous carcinoma, if you do an oil redo stain in that frozen section, it will nicely highlight the sebocytes and will help you to confirm that these are indeed fat vacuoles. So, molecular pathology of sebaceous carcinoma, there is a theory of HPV DNA positivity in sebaceous carcinoma and mutations in P53 in invasive sebaceous carcinoma and proliferating cell nuclear antigen. c-MYC also plays a role in sebaceous gland differentiation, and dysregulation of c-MYC signaling through loss of androgen receptor or aberrant p53 expression is also involved in sebaceous carcinoma. Extraocular sebaceous carcinoma, remember that it is associated with epidermal growth factor receptor signaling, so these respond to EGFR inhibitors. So differential diagnosis of sebaceous carcinoma are basal cell carcinoma with sebaceous differentiation and clear cell squamous cell carcinoma. So what are the pointers that will help you to differentiate these three is that you will have these clear cells with fat vacuoles that are oil redo positive in sebaceous carcinoma, whereas in basal cell carcinoma with sebaceous differentiation, you try to look for a palisading with a mucinous stroma. And in clear cell squamous cell carcinoma, these clear cells are rich in glycogen, so they are oil redo negative and they are PAS positive. And if you look at the immunohistochemical profile of sebaceous carcinoma, they'll be androgen receptor positive, EMA positive, BER-EP4 positive, and adipofilin positive. Whereas in basal cell carcinoma with sebaceous differentiation, it will be EMA negative and BER-EP4 positive and BCL2 positive. And clear cell squamous cell carcinoma is EMA positive, BER-EP4 negative, and AR negative, and adipofilin is negative. So these immunohistochemical stains will, to some extent, help you to differentiate sebaceous carcinoma from the other two epidermal tumors. Always remember this pagetoid spread to conjunctival epithelium or even eyelid and Muratois syndrome when you diagnose a case of sebaceous carcinoma, because sebaceous carcinoma may be the single most cutaneous manifestation also in the syndrome. Treatment is complete removal of tumor and wide surgical margin. Widespread involvement of eyelids warrant exenteration. What is the role of cytology in diagnosing a sebaceous tumor? If you do an FNAC, it should help you to differentiate between benign and malignant tumors. The presence of hyperchromasia, marked atypia, and sometimes the fat vacuoles will help you to diagnose sebaceous tumor on cytology using cytomorphological features. Syndromes associated with sebaceous tumors. Most important one is the Muratois syndrome, wherein you have occurrence of one sebaceous tumor and a visceral neoplasm. So the list of visceral malignancies that could be associated with the syndrome, and the most important one is colon carcinoma. So when you look at multiple sebaceous adenomas or sebaceoma or extraocular sebaceous carcinoma in a patient, always consider Muratois syndrome and evaluate for colon carcinoma or other carcinomas of renal, ovary, uterus, bladder, and breast, head and neck, and so on. So these syndromes are associated with microsatellite instability, wherein you have germline mutation in DNA mismatch repair genes. Before moving on to IHC, look at the histology of tumors presenting in Myottwa syndrome. There will be slight variation from the normal histology which we discussed previously. In sebaceous tumors associated with Myottwa syndrome, you're likely to have cystic morphology, presence of richly infiltrating lymphocytes, ulceration, squamous metaplasia, and intratumoral mucin. So the histology of sebaceous tumors presenting in Myottwa syndrome will have little bit of variation from the usual histology that is present in non-syndromic sporadic tumors. And when you do a IHC for MLH1, MSH2, MSH6, and PMS2, there will be loss of two of these genes in a microsatellite instability. If all the four immunomarkers are positive, like MLH1, MSH2, MS6, and PMS2, all are positive, then it is a microsatellite stable tumor. And to recall this syndrome from nevus sebaceous, Schimmelpenning-Nevus sebaceous syndrome, which is associated with epilepsy, mental retardation, and bony deformities, scalp syndrome, and association with hypophosphatemic rickets and nevus sebaceous should prompt you towards evaluating for additional anomalies. What is the role of immunohistochemistry in diagnosing sebaceous tumors? This marker here, alpha methylacyl-CoE racemase, it is a marker of beta oxidation of fatty acid, branched chain fatty acid. It is useful in prostate cancer, but for here, what is the uniqueness is this is positive in mature sebaceous. So as the gradient of differentiation decreases from sebaceous hyperplasia to sebaceous carcinoma, the positivity of a marker also decreases from in a gradient manner from sebaceous hyperplasia, and when you come towards sebaceous adenoma, they are not so much positive. Androgen receptor positivity has been very helpful to diagnose sebaceous carcinoma. It is positive because androgen receptor helps in differentiation and growth of sebaceous glands. So AR is positive in all sebaceous tumors. Sebocytes in general are positive for AR. And in infant stage of nevus sebaceous, CK14 could be positive. And when you reach puberty stage, in addition to CK14, CK17 could also be positive. And CK14, 17, and 19 are positive in the adult stage. Look at the molecular pathology of sebaceous tumors in particular. The most important one being, as we saw before, is the microsatellite instability, mutation in the DNA mismatch repair genes. Usually in sebaceous tumors, one of these four genes will show loss of expression. In this case, as you can see in this very nice paper, which is open access, there is loss of MSH6 and MSH2, whereas MLH1 and PMS2 are retained. So this shows that this particular sebaceous tumor is having some mutation in the DNA mismatch repair genes. Role of other ancillary techniques. Next generation sequencing of MMR genes will help in Myottwa syndrome, and increased HRAS and KRAS expression in sporadic sebaceous adenomas. In this scenario also sequencing is helpful. So if you look at the sebaceous carcinomas classification into extraocular and periocular, these are the molecular markers that are increased in the particular type. Extraocular is divided into three types: UV signature and POSI mutational and MSI signature. And TP53, RREB1 notch family genes are sequenced in this particular type of tumor. And HRAS and notch are seen in POSI mutational type of tumor, and TP53, RB1 and notch are seen in MSI signature. Whereas in periocular sebaceous carcinoma, you have this zinc finger 750 and gain of c-MYC and HPV DNA. So to summarize, sebaceous tumors you have to remember the gradient of differentiation from sebaceous hyperplasia to sebaceous carcinoma. So, gradient of differentiation from sebaceous hyperplasia to carcinoma is most mature to least mature. In sebaceous hyperplasia, you have mostly sebocytes, and the basaloid undifferentiated cells are seen only in the periphery minimally. And in adenoma, the polarity is maintained. You have more than 50% sebocytes and undifferentiated basaloid cells in the periphery. And in sebaceoma, it is a blue tumor where you have more than 50% basaloid cells, and there is some loss of polarity because there is intermingling of sebaceous cells and basaloid cells. And in sebaceous carcinoma, you have markedly atypical large blue cells with focal sebaceous differentiation in between, with frequent mitotic figures here and there. These are the references, and I thank Dr. Nadeem sir for giving me this wonderful opportunity for sharing whatever I have learned. Thank you, sir.